Hi, my name's Dr. Ross Hauser. Welcome to the Hauser Neck Center. One of the most common things we see at Caring Medical Florida, and Caring Medical Florida is run by Danielle Matus, my associate, is ligamentous knee instability. So we all know that knee injuries, they're one of the most common sports injuries, but actually a lot of people don't realize ligamentous knee instability is actually what causes osteoarthritis of the knee. So basically, almost any knee condition can be from ligamentous injury of the knee. If we just look at a healthy knee, we'll see that there's obviously the femur bone, the tibia bone, the fibula bone, and those bones are held together by ligaments. So the main stabilizing factor as far as like soft tissues are for the knee is not the meniscus, it's the ligaments. The ligaments are much more important as far as stabilizing the knee than the meniscus, though the meniscus, the femoral condyles, they fit into the meniscus. There's a medial meniscus and lateral meniscus. The signs and symptoms of knee joint instability are sudden episodes of the joint giving way. You get warmth in the knee, so I always tell people what you should do is after exercise, if your knee hurts, especially let's just say it's the right knee, you should take your hand right after the exercise, touch your left knee, get a sense of how hot or cold it is, and then see if the painful knee is warmer. If it's warmer, it means there is a little bit of swelling in there. It does mean that the motions that you did, the forces that you put on your knee, it actually caused the knee to get a little bit unstable. Then, because the bones were moving excessively, the synovial cells that make the joint fluid, and they make joint fluid based on motion. So if the bones were moving excessively, the synovial cells make more fluid than normal, and that's what gives you the heat. So that's just a good test. So basically also if you felt like in certain motions the knee was going to give way and you have pain, that's a sign of knee joint instability. If after exercise or after sitting a long time you feel like that the knee's stiff, stiffness is also a sign of instability. And with instability, because the joint can swell a little bit, you may not have the normal range of motion. And obviously if you're got pain on the inside of your knee, just take your thumb, boom, boom, boom. Is there a structure that's tender? Normally that tender structure are the ligaments. And knee joint instability, ligamentous knee joint instability causes all these things. Iliotibial band syndrome. Well, the iliotibial band goes from your hip joint to the lateral knee. So if you have lateral collateral ligament injury or instability on the lateral side of the knee, the body's going to call upon the iliotibial band to stabilize the knee. So if you've been diagnosed with iliotibial band syndrome and physical therapy and massage and all that and taping, it doesn't resolve it. It's probably because you have underlying ligament injury. If you have meniscal tears causing the problem, like say you have a medial meniscal tear, I can almost 100% guarantee you that if you did an ultrasound and the clinician put force on your knee, you'd see that the knee joint opens up. So the treatment isn't directed primarily at the meniscal tear, the treatment's got to be directed at the instability. So that involves with treating comprehensively all the ligaments along with the meniscal tear. So often in cases like that, we'll use Prolotherapy with PRP, platelet-rich plasma, which has growth factors, and inject that into the ligaments and the meniscus. Baker cyst, right? Baker cyst just means that the joint fluid, which is normally supposed to be 1 to 3 cc's, 1 to 3 cc's, well, if you have, think about this, if you have joint instability and the synovial cells are continually making joint fluid, they're making joint fluid, they're making more joint fluid. Eventually there's so much joint fluid that the capsule, which is surrounded by ligaments, the capsule breaks and then the joint fluid goes into the back of the knee. So when it goes into the back of the knee, that's called a Baker cyst. So you can drain the Baker cyst, but to resolve it, you have to stabilize the knee. So we do drain the cyst, but then we also do prolotherapy to stabilize it. Bone spurs are the body's attempt to stabilize the knee. Chondromalacia patella, you have patellar instability, so the cartilage underneath the patella gets worn out. The cause of that is ligamentous joint instability typically. Osteochondral defects are where the cartilage chips off. It normally happens in young people, adolescent, teenagers, and the treatment of that is, resolve the underlying ligament injury, and the treatment of that is prolotherapy. And there's all different kinds of knee instabilities. The way we document knee instabilities are either with motion X-ray or motion ultrasound, that we can tell what kind of instability there is. So with exercise, with pickleball, with soccer, with football, with cutting and twisting, running, there's all kind of forces. So you can understand if there's a force going here on this bone and there's a force going there, that these ligaments get stretched out, and eventually if they get stretched out too much, they can get torn. And that's what ligament joint instability is. The ligaments become dysfunctional. So now during normal activities or with sports, the bones move too much. When they move too much, they cause too much force on the other joint structures. So the other joint structures start to break down. So this is an animal study where they're stretching out the anterior cruciate ligament. And you can see there's a certain period of time where the anterior cruciate ligament, which is normally 40 millimeters, it's elongated by 4 millimeters. So you have this 40, an inch and a half long anterior cruciate ligament, then you're stretching it 10%. So once you stretch it 10%, you start getting little tears that you can only see under a microscope. And all you have to do is, once you get to that point, you just have to stretch it about 2 more millimeters, then the thing tears completely. So this is kind of the prolotherapy zone, right? Normally when a ligament is torn completely, you would have to get that surgical repaired, but it's interesting. It used to be all Achilles, complete Achilles tendon tears, you would have to treat them surgically. Or even 2 days ago or 3 days ago, we had a person with a complete plantar fascia tear that the doctors were treating it conservatively. So even like really big complete tears now, except for the anterior cruciate ligament, they're really treating it conservatively. So how we do it is in complete tears, we do limit the motion. So we might brace somebody and then we inject PRP into the area, which is going to produce a lot of growth factors. So it's just interesting how medicine is evolving, if I can use that term, into more and more conservative care, like non-surgical care. Like when I started, there's so many operations that they don't do anymore, and it's just conservative. I've always been a conservative doctor, and it's amazing how many things you can get better just by common sense. So common sense would be somebody has a shoulder instability and their ligaments are damaged, so let's treat the ligaments, treat the labrum, treat the tendons, if they're painful. Then we know this motion stretches the ligament the most, so why don't we, while you're healing, we'll limit this motion. So you can do things like this, do things where your elbow's at your side, so we're giving the body a chance to heal. And ligaments and tendons heal best with some motion. So even today, my good friend, Pastor Russ, one of his relatives, got a really bad ankle injury. And I know if that person went to the ER, they would have said, oh, you need rest, ice, compression, elevation, RICE. But I told this person, you need meat. Movement, exercise, natural analgesics like enzymes, and therapy like going into a pool and walking or swimming. You actually need the motion. And I said to them, I don't know if you know this, but the person you're talking to invented the mnemonic meat in 1995. And it's really been, so just for fun, I went on the internet and it's amazing. The meat protocol is used all over the globe. So that's kind of cool. And I made the mnemonic meat as a because I'm a very sarcastic person, because the prior thing was rice, which is vegetarian, so I made the mnemonic meat. So that's if you want to know the story of how the meat protocol came about, that was in 1995, just as a sarcasm to rice. And then it turned out the person who made the rice mnemonic in like 1970s, within like a few years of me coming out with meat, eventually that person acknowledged that the rice protocol absolutely inhibits soft tissue injuries, and you actually need the meat protocol, or you need to do movement. This is probably the most important slide that you'll ever see as it relates to ligaments, because you get it. So this is basically based on research for an anterior cruciate ligament. So they found out that upwards of 10 times the body weight with activity when you have a ligament injury of the knee, especially the anterior cruciate ligament, the forces on the adjacent ligaments go up 400 to 500%. You get inflammatory synovial fluid, the medial collateral ligament eventually tears. It initiates meniscus and articular cartilage destruction. Basically, you get bone marrow lesions. The force on the knee with activity, it shifts to wherever the ligament injury is. So if the anterior cruciate ligament is here, and most of the forces on the knee are on the medial side, then the forces on the knee, like when you're walking or moving, they go toward the periphery. And that's where you get osteochondral lesions on the medial condyle here, like osteochondrous dissecans, and then you get medial meniscal tears here. And then, of course, there's a lot more forces on the tendons, so eventually you end up with quadriceps tendinosis, hamstring tendinosis. So if you have a chronic iliotibial band syndrome, hamstring tendinopathy, jumper's knee, or quadriceps tendinosis or tendinitis, it's likely that you have chronic ligamentous knee instability, and you need to get prolotherapy on the ligaments. And these are all the various tendons that get a lot more force when you have ligamentous dysfunction of the knee. And then physical exam, so we're doing ultrasound, there's Danielle, and then she's going to put a stressor maneuver and see the knee joint open up. So watch this. See how it opens up. See how the meniscus pops in and out. See how it's popping in and out. So that's what causes meniscal tears, and that's what causes your knee pain. So that's it. So you need to get an ultrasound exam where somebody's stressing the knee and they're looking at what's going on in real time, and then you need to get those ligaments tightened. Now, normally in the office here, we treat somebody about once a month, but there's definitely athletes that say, Doc, come on, I don't want to be off for 3 months, so then we'll speed it up. We'll speed the treatment up like every 2 weeks. So, and obviously there are definitely times where we let athletes do the athletics, but usually there's some kind of modification. So if somebody's a runner and they want to keep running, I might have them run in a pool. If they're a tennis player, I'll have them do other things beside running. I might have them do core work, balance work, but you know, obviously athletes want to get back to athletics. But the thing is, if you don't get this repaired, it's just going to get worse and worse and worse. So that's what we're looking for, is the meniscus popping in and out, and is the joint opening. And then when you have knee instability, you get all kinds of inflammatory cells and substances go into the knee. Because of the extra motion, the synovial cells make all this inflammatory fluid. That's why when you take ibuprofen or you take Aleve, it feels better. But think about if you take Aleve or an anti-inflammatory and then you're going to go play tennis, because without that, it would hurt too much. You're just playing Russian roulette, because you have knee joint instability. Now you can't feel it, and then you go play. Like, it's going to be a nightmare. You're going to really wreck your knee to the point where you have a terminal knee, and a terminal knee, that's a knee replacement. And really, that's what you want to do when it's totally correctable. If you just get some prolotherapy and tighten it up, then you won't make all these inflammatory markers. This just shows that the severity of the ACL weakness or laxity correlates with how much cartilage degeneration you have. So if you want to know what's causing your cartilage to thin, what's causing you to get more bone on bone, what's causing you on the medial side of your knee to have narrow cartilage, but the other side to have good cartilage. It's ligament dysfunction, it's ligament laxity, it's ligament injury. So you need to get those ligaments tight, and the way you do that is with prolotherapy. And this is basically what it looks like. Normal knee, you get a ligament injury, then all of a sudden on the side of the ligament injury, the cartilage wears out, then you end up with a terminal knee. So this is it. So you have to correct this. The treatment is not to have stem cells injected into here because you got that. Yeah, you could do that, but you got to also correct this. You can't just direct it at this. This is caused by that. So you have to do comprehensive prolotherapy around the knee joint and all the ligaments that are incompetent, that are dysfunctional, that are torn, that are degenerated, that are injured. And if you repair this, the forces on this get better, and then the knee joint regenerates and the cartilage regenerates. This is what it looks like. Ligament injury, basically you get altered joint mechanics. Basically then the shock absorbing capacity of the bone goes down, the cartilage starts breaking, and then the cartilage breaks down and you get whole joint gangrene. So basically the pressures caused by ligament dysfunction on the knee cause extra forces to be on all the tissues of the knee, so they all degenerate. The cells start dying. So when the cartilage cells die, yeah, the cartilage gets thin. When the tendon cells die, you get tendinosis and eventually tendon tears. When the ligament cells die, you get ligamentosis or degenerated ligament, and eventually the ligaments tear. When the meniscal cells die, you get meniscus degeneration, and eventually meniscus tears. In the spine, you get the disc cells die, then you get disc degeneration, then eventually you get tears in the disc. In the shoulder and the hip, when the glenoid labrum, which is like a cup, like a suction cup, when those cells die, you get labral degeneration, and then eventually you get a labral tear. So the treatment is to do comprehensive treatment of prolotherapy around the joint. When you treat it, the joint gets stable, then the cells regenerate. And if you're left untreated, you're going to get a terminal knee that ultimately is going to need a knee replacement. So my encouragement to you is, if you have a knee problem, a chronic knee problem, no matter what the diagnosis, you have to look at, do I have knee instability? So the way you diagnose that is you have to look at what's going on with the bones while they're under stress. So we do that primarily with ultrasound, though we can do it with motion x-ray. And then when knee instability is found, the treatment is prolotherapy with careful graded exercise afterwards. As the knee gets more and more stable, the amount of exercise increases till the person is back to all their exercise. So that's kind of the process. Depending on the person, we see people every couple weeks to every 6 weeks. And then most people, 4 or 5 visits, what they need to resolve the issue. But again, that takes us looking at you and evaluating you and knowing your specific case, but just know the outlook is good.